So good morning. We are starting the last session of clinical cases for the symposium, and the first participant will be Tom Kato. Tom, as you know, couldn't be here. He's in New York. It should be 2:45 or something like that in New York. He's waiting for us at the Zoom. So we start by his case. Tom, can you hear us? Okay, Tom, can you hear us now? Yes. Tom, can you hear us? We still don't have sound here.
You don't have a sound of me?
Yeah. Can you hear us now?
Yes.
Oh, great.
I can hear you very well.
So Tom, thank you. I know it's very late there, and we know why you are not here today, because you have a very difficult case there in New York. Can you explain us a little bit about your case, the transplant case?
Yeah, sure. So there's a 28-year-old female patient referred from Texas. So she had an autoimmune hepatitis, long-standing history of liver cirrhosis, and then she developed portal vein thrombosis, portal mesenteric thrombosis. And then people in Texas tried to open it with the tips and ended up clotting everything. So she decompensated so badly. She's a male of 40. You know, at one point she was intubated in coma, and now that she's extubated and awake, still on CVVH in ICU. So we got her from Texas and waiting for the organ. Male of 40 should get organ any moment, but still I haven't had it for the past 4 days. So that's why I couldn't leave. So I'm hoping that I can get the organ as soon as possible, and then I will be on the flight to Milan.
Okay, let's hope you can make it for the patient, because it's for sure a very difficult situation.
Yeah.
Okay, so you want to start presenting your case?
Yes. Thank you very much for everyone. I'm sorry that I couldn't come in person. I'm going to present a case of fibroamyloid HCC. So this is a 19-year-old male with history of fibroamyloid HCC. So the patient was found to have a left lobe liver tumor and a large solitary lymph node metastasis at the head of the pancreas. So this is the CT scan. So there is a large left lobe tumor, as you see it in there, but also at the same time, he also had, this was left lobe tumor, and then this is the pancreas head tumor. So it looks like it's continuous. It's not a continuous, it's a totally separate tumor. So this is the pancreas head tumor, and then this is the liver tumor. So this is the liver tumor, this is the pancreatic head tumor. Doesn't seem to have any other obvious metastatic lymph node. And then biopsy was consistent with fibroamyloid CC, and then DNAJB1 PRKACA fusion was genetically confirmed. This is the most modern way of diagnosing fibroamyloid CC because they have all common mutation. So the question is what to do next. So in this case, you could consider chemotherapy, neoadjuvant chemotherapy, or you could go upfront resection, although this is a metastatic disease. I'm not going to ask everybody what you guys think for the interest of time. But in this particular case, we select to do neoadjuvant chemotherapy, and I'll tell you why. So patient received chemo with Gemox lenvatinib for 6 months, about 10 cycles. Why we did that? So fibroamyloid historically, there's no effective chemotherapy, and there's really no proven published data. However, recently, our group, Columbia University and also Rush University in Chicago, we gathered together, and then we've been attracting many fibroamyloid HCC patients to our system. So from our own experience, we came up with several different chemo regimens, and one of which is a Gemox and lenvatinib, based on some in vivo data of the tumor sensitivity. And then we've been doing this for quite some time now with a good number of cases. So this is the ASCO paper presented this year. And then you can see the waterfall plot here of the Gemox lenvatinib in 27 cases of fibroamyloid HCC. So 27 doesn't sound like a huge experience, but in fibroamyloid, to have a same chemo regimen, which is actually a very, very large experience. So as you see, there are some patients didn't have much response, but most of them had either stable disease or partial response. And then a lot of them end up having neoadjuvant surgical resection after the chemotherapy. So in this particular case, we did the Gemox lenvatinib for him. It didn't really respond dramatically. The tumor size actually didn't decrease, but the Signatera value decreased from 19 to 13 at the early on the chemotherapy. So what Signatera is a circulating tumor DNA. In a fibroamyloid HCC, there has been no reliable markers. So AFP is negative in most cases, and a vitamin B12 level, ammonia level, has been proposed as a marker, but it's really not useful. So we've been using ctDNA for fibroamyloid HCC for monitoring, and it seems quite effective. This is again the ASCO paper presented with a ctDNA used for fibroamyloid HCC, which is a Signatera in a commercial name. So after 10 cycles of chemo, he didn't really respond in terms of the shrinkage of the tumor, but he had a stable disease with the ctDNA response. So what is the really next step?
Okay, so probably have some comments from the audience regarding this. Continue chemo or resection in this case. Okay, just one thing, Tom. usually this type of HCC in non-cirrhotic liver. So you spoke about metastatic disease. It is, I would say, would you agree it's a local regional disease? You're speaking about one lymph node in station 13, retropancreatic. So this should be regarded probably not as purely metastatic, but as local regional, don't you agree?
Yeah, I do agree. I do agree. So you could have done an upfront resection because based on the idea there's really not much, chemo available. But based on our recent experiences, gemoxylenvatinib, it seems that it's more logical to consider a neoadjuvant approach because, a lot of children or the fibromegaly cases that we do upfront resection on this type of local regional or metastatic disease, they really recur very quickly after the surgery. But these cases who had a neoadjuvant seems to have a longer time interval for recurrence.
Yes, and in fact, I think the experience of most of us in these patients with important lymph node disease is a rapid recurrence after resection. So I think so. What did you do?
So in this case, we did this neoadjuvant chemo and did a resection. So the patient underwent combined Whipple precision liver resection. In this particular case, or not actually this particular case, this pancreatic regional lymph node is very common in the fibromegaly case. And I've been doing Whipple with liver resection. In that approach, we can clean up the lymphatics between the liver and the pancreas very well. And then does it really make a difference in outcome? We really don't know, but we have some cases that included combined Whipple and liver resection. We see the outcome. It was R0 resection for both lymph node in the pancreas and the liver. However, he had one additional lymph node positive in addition to the large non-metastatic node. This case, actually, these are the experience. I'm putting together fibromegaly surgical experience paper with the Rush University and the Columbia experience. We have about 32 cases of the surgical resection in fibromegaly, including metastatic disease. And it seems even including metastatic disease, I'm not going to show entire paper because it's not done yet. We seems to see a good enough overall survival and a disease-free survival, particularly when it's combined with those neoadjuvant chemotherapy, effective neoadjuvant chemotherapy. So this is something the paper to be sent out in sometime this year. So please wait for that. So his Signatera experience, ctDNA experience, so he had a continuous decline, although it's a slow decline while he was on chemo, but suddenly, very end of the chemo, it actually jumped up. So that's when we did a surgery. And then since the surgery, it's still not that long-term follow-up yet because it was November last year. But we've been seeing zero ctDNA value with no evidence of recurrence. So it is still very early, but it seems that he seems to belong to the category of long-term disease-free interval. I'm not so sure if it's going to be curative, but at least that's how it is right now.
Okay.
And one other thing is that actually after the surgery, he's on a post-op immunotherapy. So I'll give you one more reason why, one more graph and showing why the immunotherapy works. So this is the overall experience is our group. So gemoxylenvatinib induction, overall now we have up to 36 cases, but there are some other patients received nivolumab curserin or nivolumab gem curserin or triple immunotherapy, interferon, capecitabine, and nivolumab. So this interferon, capecitabine, and nivolumab was traditional protocol done by MD Anderson, and it seems also effective in a maintenance phase. All these are totally anecdotal data. There's no clinical trial, but the fibromyalgia being so small group, we can't really reach the number to do a real comparative randomized clinical trial. So far our strategy, we think is the best strategy, up from gemox lenvatinib, do the resection and put them on triple immunotherapy if they tolerate it well. And he's on that regimen currently and very, very active, doing well. He's playing soccer and then very, very good picture perfect outcome so far.
Okay, very, very well. So just two questions. So do you have any difference in survival in those patients that you resected with induction chemotherapy and the other group? Do you see a difference?
So we haven't put together the paper yet, but it seems to be the one who had a effective induction, somebody who didn't get none of those induction didn't have much of an effect, but effective induction with gemox lenvatinib cases, they seems to have a slower recurrence than the other, so the longer disease-free interval. But these are the paper currently being analyzed.
And the second question would be, you had this lymph node, this large lymph node next to the head of the pancreas. Why did you have to do a Whipple in this particular case?
Right. So this is still sort of my belief, and I don't necessarily know if that's gonna be the real importance in the future. This one particular one was very close to pancreas, so it'll be harder to do complete alveolar resection without a pancreas resection. But a lot of cases, the lymph node can be removed without Whipple. And then we've been debating if that's really necessary, but when it comes to the real large one, if you do Whipple, at least in my personal experience, they tend to recur slower, and also they don't recur at the hepatic hilum. So the hepatic hilum recurrence right after resection has been a hard target to treat. But if the distal recurrence outside of hepatic hilum, there have been second resection possible, and also some other targeted therapy or the needle therapy, radiofrequency ablation has been possible. So this is again totally unproven approach, but I do believe that clean out all the lymph node by doing a Whipple is a lot more than just do lymphadenectomy. And then they can delay the local recurrence in fibromyalgia cases. But again, this is a small number of cases. If you guys have any other experience, please let me know. And also I'd like to know from the audience, what are their overall fibromyalgia experience? And if you guys are interested in joining us for gemox, lenvatinib, and other chemotherapy and in the resection group, we have a international tumor board every Thursday. Getting many surgeons and the oncologists coming from all over the country, and as well as overseas outside of the United States. So please let me know. And it could be very, very interesting to get the European input in this group.
Okay, thanks a lot, Tom. So, questions, Professor Bismuth?
No, it's a beautiful case, but I would like to ask you, Dr. Kato, what time it is in New York?
It's 3 o'clock, 3 in the morning.
And we are waiting the donor for this difficult transplantation?
Yeah, I'm still waiting for the donor for difficult transplantation, but of course I slept in between.
I know you are expert in multivisceral transplantation. We have no time he planned to do liver and small bowel transplantation. This is correct?
Yes, we could do liver and small bowel only. However, though, the tip stent right now is in the splenic vein, and it's completely occluded. So I'm not so sure the pancreas viability on this one. So we may have to do whole multivisceral.
I mean, you plan to do only liver and small bowel. Nothing else.
No, we are planning to multivisceral. If the pancreas is viable, then we may be able to leave pancreas and stomach. But it seems that because the splenic vein is completely thrombosed and the tip stent is in the splenic vein, so I'm not so sure the viability of the pancreas.
Okay. Good. So thank you a lot. Thank you. Try to sleep a little now.
Thank you
I
very
will.
much, Tom.
Thank
It
you.
was a pleasure.
Thank you.
We hope to
Really,
see you.
thank you to be with us today, even so far. Thank you.
Thank you. I will stay on the Zoom link for a while. Or are you gonna be disconnected me? And I can disconnect and sleep.
Sorry. Okay, so we disconnect you so that you can rest a little bit.
Okay.
Thank you.
Thank you. Thank you very much.
So the next case is Riccardo. That's
Okay. So good morning, everyone. I'm very happy to be with you, all of you. And I want to thank Mr. Bismuth and my friend Guido Torcilli to invite me. And I don't present a case, a surgical case like I saw in 2 days, but as you know, I'm retired. If you don't know, it's easy to imagine. And so this is a case very important for me because it's the case that happened one of my friends, nice friend, and she's a lady, 70 years old, pediatric med doctor. And he's a very, she's in good state for until 2 months ago, when she started to have some pain on the left abdominal region, like sort of umbilical line, and fatigue, reduced appetite, and dyspepsia. So we asked for echography, and the echography shows this hepatomegaly and multiple lesion, multiple nodule in the parenchyma, and the sclerotic and calcific gallbladder. So quickly we asked for a CT scan, thoracoabdominal scan, and a blood test. And we saw the nodule on the left lung, with the small lungs subpleural, and on the liver there was a gallbladder with the big distensions, with the multiple confluent nodule on the parenchyma, and on the something coming from the fundus of the gallbladder, and arrived until reaching the head of the pancreas and the stomach wall. And the blood test was almost normal, but with slight hepatic insufficiency, like gamma-ZT, but what is important is the oncological aspect of alpha-fetoprotein, like 600,000 milligram, the other marker. So can you imagine something for this kind of lady? Come on. She is very ill. For me, it's the first time that I saw
Okay.
600,000 for alpha-fetoprotein.
It can be an hepatocellular carcinoma, massive hepatocellular carcinoma, but you have to exclude some metastatic disease with alpha-fetoprotein very high, like that, which
Yeah.
can be a stomach. Anyway, so
And
I would have done a biopsy anyway,
yes,
even if
we
it's,
did.
even it's so high, so unusual
Not
presentation.
unusual.
Could be, for example, a germinative tumor.
Why? Good response. So, because we think about cholangiocarcinoma, ACC, hepatoblastoma, germinal metastatic tumor, or hepatic primary germinal tumor, or some other bodies. So we did a biopsy, and for many reasons, the conclusion was there's a germinal cell tumor. And I saw in the literature was the primary tumor. I think there are 20 cases, 20, 25 cases. And so we tried to find some primary tumor, but we didn't see any tumor coming from the uterus or the other kind of fetus. So we put the lady on the chemotherapy with cisplatin, bleomycina, and etoposide with the schema that the oncologist said. And after the first chemotherapy, there was a dramatic decrease of the alpha-fetoprotein, and that remained around 2,000 years, 3,000. But after the second cycle, she came back at 3,000, and now it's finished the last therapy, the last sequence of chemotherapy, and we did a CT scan to see the control, and we saw a very important reduction of the coming from the lung, but also on the liver we have a decrease of the mass, very important. But now we have to stop the chemotherapy for the toxic effect of the cisplatin, and we are coming to wait, and what we have to do now, to wait 2 months and trying to do a second line therapy, or we don't know. I talked with the oncologists, and they said that we have to see. And we want to see what is going on. So I'm here to ask in this platea who have some experience about this kind of tumor that for me is the first time that I heard this kind of diagnosis.
Any comments? Rashad, please.
Thank you for your presentation. It's very interesting. I remember I've only seen one case like that. I presented actually in Geneva in 2009. It was a gentleman who had he was known to have an HCV, and we found a focal lesion and high alpha-fetoprotein. And we removed it as being, thinking it's HCC, and proved to be a germinal tumor. I remember the pathologist rang me, say, look for the primary. He was a male patient, and we did it. We checked it all over, and it was actually a primary. Very few cases, usually asymptomatic. They present with a large tumor, And some of them, those who respond for chemotherapy, you can think for surgery after that. But very few cases, and I think there is a French presentation by Dr. called Tommy, who asked for to have a special register for them, since there are very few cases. But for us, I mean, it was accidentally discovered. It was 5 centimeters, but most of the literature, you find tumor of 10, 12, 15 centimeters. I think, I don't know what to...
I think there is a paper with Tommy and Daniel Cherki together.
Justement, c'était les deux ensemble. They reported the case, and they suggested to have a special register since these cases are very, very rare. I have it's only one case I've seen.
Yes.
But it was, I mean, it was by pure chance that we discovered it accidentally. In your case, it's difficult because it's bilobar. I don't know whether you can offer a transplant for her or...
I don't know what is very... I don't know. Monsieur Bismuth, vous avez do you have some experience in that?
Mon souvenir, je n'ai jamais rencontré. Sorry, I never have a case like this one. Perhaps I pass. I did not recognize it. I don't know. But what is the prognostic in this case?
I heard. I don't know, because what I say, it came from the literature, because I never followed this patient like with this kind of tumor. So, if he's generally is a big tumor, one lesion, no?
Most of the report, I think there was 30 or odd cases there, all over the literature review when we did. Most of them was one big tumor, not multiple like
Not
this
like.
one.
So the difficulty is it really a primary liver tumor, this one, or is it metastatic?
The primary are very, very few of them.
Very few, I
Very
know.
few. That's what I say. Because I remember that day the pathologist rang me and they say, are you sure? I mean, there's a male patient that there isn't any problem with the testicles or tumor. And I said, I've examined, and we did a repeated examination at the Doppler, and we couldn't find any evidence tumor elsewhere. So we labeled it as a primary germinal tumor of the liver.
Are you the only one in this room that sees a tumor like this? You? Yeah. Oh. And what, small? And you reflect?
Same, it was a surprise, a pathological surprise in a tumor, a resectable tumor. Anyway, in those germinal tumor, usually they respond to chemotherapy, and well, now I think it's a problem of second-line chemotherapy, but you had a beautiful response, and it's usual. It's usual, but of course, this is a very heavy chemotherapy, so you have to change.
Yeah, and the second line is...
Second line, oncological problem, unfortunately.
So, okay. Thank you very much for your attention.
Thank you very much. Okay, so the next speaker is Katsunori. He has a case to present from Japan.
Good morning, everyone. Thank you, Professor Bismuth, and thank you, Professor Pellicci, and thank you for all of you. Sorry.
You have to speak a little closer to the microphone. I'm not hearing very well.
I'm honored to be able to speak here today. I'm Katsunori Imai from Kumamoto University, Japan. Today's my topic is treatment for advanced colorectal liver metastasis, focusing on chemotherapy-induced liver injury. So nowadays, preoperative chemotherapy play a very important role for the treatment of colorectal liver metastasis, but there are several problems. How to treat in case of progression disease, how to treat disappearing lesions, and no clear evidence for resectable liver metastasis. And this is today's topics, how to treat chemotherapy-induced liver injury. So how should we treat chemotherapy-induced liver injury? Only stop chemotherapy? So if we stop chemotherapy and wait for the improvement of liver function, of course, we will face the risk of tumor progression. If we continue chemotherapy, liver injury is not improved, of course, and liver resection cannot be performed. So I will present about two experiences. Case one is 56 years old male. He was diagnosed as bowel obstruction because of advanced cervical cancer with multiple urinoba liver metastasis, like this, you can see here. And he first underwent ileocecal resection with D3 lymph node dissection because of the bowel obstruction in another hospital. And he received Xerox and bevacizumab 4 courses with good response. He needed extended right hepatectomy, but the patient FLR was 25% and ICG R15 was 40%, maybe because of the chemotherapy-induced liver injury. So what is the next move?
Okay, so any comments? Can I ask Guido if he would perform a right hepatectomy in these patients? Or is it a patient that you can think about doing a parenchymal preserving hepatectomy?
I don't want, but I don't want to be asked, but I have to answer.
Can we see the pictures again?
Of course.
Yes. Yes, we may avoid the right hepatectomy.
You would avoid the right hepatectomy. Okay, so one of the options from Guido is to do a parenchymal sparing hepatectomy.
We say parenchyma sparing major hepatectomy, because at the end is not a limited resection.
Of course.
We want to find a way to keep at least the sectional branch to the 5/8. The target is keep the liver scaffold. Of course, we remove a lot of liver, but we do not amputate the major vessel. So it's this is the difference.
Okay. Any other options? John.
Well, we'll wait a while. You stop the chemotherapy, usually wait 6 to 7 weeks, reassess whether it's ICG or mebrofilament scan, and maybe consider whether you can do a right hepatectomy. There's a small lesion in segment 4 and just combined with non-anatomical, but do you really need to do an extended right? Do you need to do extended right in this case?
Yes, because of the tumor was very close to the main branch of right portal system. So I thought that in this case, the parenchyma sparing hepatectomy is impossible. So. Can you show the first CT?
Problem of ICG retention also, that is very high.
The future remnant liver is small, so we can do an embolization, even a liver deprivation, and probably with the response to the chemotherapy, keep a large part of segment 4. That is the first point. The second point is that he only had 4 chemotherapy.
Yeah.
Usually the alteration due to chemotherapy happen at 6 or more courses. It's rare to have really difficult cases after 4 cases only. So I won't wait. I would do now embolization and operate 6 weeks or 4 weeks after.
I would also do this. Is there any chance there is an underlying liver disease also?
I think no, because he had no hepatitis, chronic hepatitis, or no alcohol abuse. So unfortunately, we have no data of the liver function before chemo, but I thought that his liver function before chemotherapy is normal. So, of course, only 4 courses of chemo, his impaired liver function was due to chemotherapy.
So I would probably propose a B embolization with contralateral biopsy and assess the response by volume.
Or maybe, yeah, first...
Fernando. Oh, sorry, Mark.
I've never seen SOS NRH after 4 cycles. I don't know if everyone has seen it. We've seen it in the beginning, years back. I presented, I think, 15 years back, when we really gave 12, 14, 16 cycles. Then you see the NRH. I've never seen it now, so I'm not afraid of that. And actually, as Laurence, as you do a right portal embolization, either a drag and a double embolization, you just do a resection without problems, I think.
Okay, Guido?
I was just, because I don't want to appear as a Superman that propose fancy thing without proving. You know, the only problem the major problem in this perspective are not the big lesion, and not the big lesion in the contact with the middle hepatic vein. The major problem are the 2 lesions behind, on the left side of the right hepatic vein and in the paracaval portion. The 2 tiny lesions. This is the only issue that is doubtful. These 2 lesions. The other, you can do a parenchymal sparing. You can puncture, or anyway, do a right posterior sectionectomy, extend it a little bit to there, and an upper resection of the segment 4 superior with detachment of the middle hepatic vein. Not just to understand, to let you understand the thinking, because otherwise I look like a foolish guy that is saying, well, we can do whatever. No, it's not like this.
Very well.
Some nodules, or would you resect them all? Would you resect them surgically all, or would you combine resection and thermoablation?
We try always to remove all. We did only 5 or 4 cases with thermal ablation, and I may say that in one case there was a liver failure due to the excessive liver failure of the microwave, because it is difficult to control the results. So it would have been better to, but if possible, and if it does not change the volume, the future liver remnant that we calculate, if we have margin, we want to remove.
Fernando?
Yes, thank you, Katsunori, great case. On one side, I agree with what has been said regarding chemotherapy-induced liver injury. Only 4 cycles, and if it was oxaliplatin, you would be fearing of SOS, sinusoid obstruction syndrome. Yeah. And she received also bevacizumab, and it's known to be protective against SOS. So I think 4 cycles bevacizumab, that would be weird. And on the other side, when you see the spleen, I don't think it changed much between the first and the second CT scan, and sometimes you can see spleen enlargement secondary to portal hypertension. So I wouldn't be fearing that. And regarding the second point, which is, okay, if you are going to do a right hepatectomy, you fear volume, probably you could do a scintigraphy to know the regional function of the future liver remnant before attempting occluding the right portal vein. Thank you.
Okay, so what did you do?
Can I proceed, move to the next slide? So I will summarize the course of this patient. After only 4 courses of chemo, significant response was observed, but ICG was 40%. Remnant, future remnant liver is 25%. So this is performed in another hospital. They stopped the chemo for 3 months. And ICG was a little bit improved, but the disease progression was observed. And then the patient were referred to our hospital. So we first performed portal vein embolization of the right liver. And we continue the chemotherapy using S1. This is a compound agent of.
Sorry, what is S1?
No. S1 is made in Japan. I will show the final slide. Okay. The S1 is now key drugs only for not only for the colorectal cancer, but also pancreatic cancer, gastric cancer, and cholangiocarcinoma in Japan. We start the chemotherapy immediately after portal vein embolization for 4 months. Of course, after portal vein embolization, the future liver remnant was significantly increased. And then the ICG was significantly improved, almost normal after 4 months. So during this chemotherapy, we can keep stable disease. So no disease progression was observed. So we can perform extended right hepatectomy without any complications. So next, I will show you the second case. 73-year-old female. She was diagnosed as sigmoid colon cancer with multiple, very extended bilobar liver metastasis. She received modified FOLFOX6 and panitumumab, 30 courses, with excellent response. So we planned 2-stage hepatectomy, but the percent FLR was 34.7% and ICG was 32.7%. Sorry.
Right.
So, okay.
This was around 6 months of chemotherapy. 13 courses.
13, yes. So maybe because of the long period of chemo, the liver chemotherapy-induced liver injury was developed. So what is the next move?
Chemotherapy, says Gina. Any other option? No.
Surgery.
So parenchymal sparing surgery. Tell me something. So you had the same result with the previous case. You stopped chemotherapy and you had a dramatic response in terms of ICG retention that improved a lot.
Actually, yes, but in this case, this patient was treated in our hospital from the beginning, so we never stopped chemotherapy. So can I move to the next slide? So I will summarize. She received Folfox and panitumab 30 courses.
So just one information, so we are live on YouTube. So if anyone does not agree, should say it now. Okay, it's just an information.
Okay. So we first performed first stage hepatectomy, which means the tumor cleaning of the left lobe and resection of the primary high anterior resection.
Are you going to do a two-stage hepatectomy? Two-stage hepatectomy was the plan.
We planned two-stage hepatectomy, and I first performed, of course, first stage. At this point, ICG was 36.7%. So we immediately start efurocobalin and panitumab for focus. I mean, I exclude the oxaliplatin. It's a causing agent of liver injury. So after 3 months, ICG was improved, reached to almost 18%, and percent FLR was 53.6%. So we decided to perform second stage extended right hepatectomy with alveolar resection. Post-operative cause is refractory ascites only. So I will show our policies. Stop chemo, of course, face of the risk of tumor progression. So continue chemotherapy without causing agent, which means oxaliplatin or irinotecan. So this is my opinion, but if we perform doublet and anti-EGFR antibody, cetuximab or panitumab, we continue chemo with efurocobalin and targeting agent. We exclude the oxali or irinotecan. If we perform doublet and bevacizumab, we have to consider the 6 weeks washout period. It's very complicated in such case. So we usually use capecitabine or S1. The point is keep stable disease until the liver function is improved. So this is the summary slide. Here I presented 2 representative cases of chemotherapy-induced liver injury, which was successfully treated. The point is how to keep stable disease while waiting for the improvement of impaired liver function. So in case of cetuximab or panitumab, just remove oxaliplatin or irinotecan. Considering the washout period of bevacizumab, we use S1, I'm not sure, only Japan, or capecitabine to keep silent disease. So, I would like to ask all of you how to treat chemotherapy-induced liver injury. And this is a slide of S1. S1 is a compound agent, including tegafur, gimelacel, and otelacel. Tegafur will change to 5-FU in vivo, and then gimelacel stop the DPD, which accelerate the metabolism. So the effect of 5-FU is enhanced, and otelacel stop the becoming FUTP, which is called the side effect. So otelacel decrease the effect of toxicity. This is the S1. Thank you for your kind attention.
Thank you very much, Katsunori.
Thank you. Thank you very much.
Thank you. Thank you very much.
Oh, I can call Manuel Jaklitsch. Voilà.
There we go. Thank you. Good morning to all. Thank you much. So, the case of today is a 7-month-old male who was born prematurely at 32 weeks of gestation in a twin pregnancy with a stillborn brother. After birth, he had neonatal respiratory distress syndrome and was on mechanical ventilation for 14 days with a total of 1 month of hospital stay. At his dispatch home, he was diagnosed with a psychomotor development retardation syndrome and a congenital hydrocephalus. So about 7 months later, 6 months later, her mother came through the outpatient clinic with the complaint of a palpable abdominal mass in the right hypochondrium and a failure to thrive. The clinical laboratories are normal with exception of, as you can see, alpha fetoprotein of 60,500 units per milliliter. And following this, a CT scan was performed. This is the arterial phase with an early venous phase. There's a bit of a mix, where you can see this large mass that is permanent in the left liver lobe, segment 2, 3, 4, and 1, with a displacement of the portal vein, and the arterial hepatic arteries are not visible in this at this stage. So, with this is the late venous phase. We can see the left hepatic vein and the middle hepatic vein involved in the tumor. You can see it here, where the left, the middle, right is free. So, a liver biopsy was performed as must, and diagnosis of a hepatoblastoma with pure fetal epithelial differentiation was made. Glipcan-3 and beta-catenin positive, CK7, CK20 negative. And it is a liver-only disease at this stage. Immediately posterior to this, the pretext protocol was called in with the pediatric surgeons, and the pretreatment extent of disease was established. It was categorized as a grade 3, where one continuous segment is tumor-free, that is the posterior right segment. And the pretext therapeutic plan was built up and consisted in 4 cycles of cisplatin, vincistin, and 5-FU to assess surgical exploration after these 4 months. This is in January 2022. The second cycle of chemotherapy, the patient presented with pancytopenia. At that time, it was classified as a chemotoxicity. And as you can see, these are the blood CBC values. Alpha-fetoprotein is not decreasing in chemotherapy, and at the third cycle, we have 133,000 units. So it was planned to change of protocol to a high-risk plateau protocol. And this was done for 4 more cycles. The second cycle, you can see alpha-fetoprotein is now down to 7,400. At the culmination of these 4 cycles, for a total of 7 cycles, alpha-fetoprotein is at 2,234. This is in July 2002. A new CT scan is performed with a massive reduction in tumor size, and the visualization now of the hepatic artery. Sorry, and you can see the left hepatic artery. I don't know if you can see my mouse. Yes, the left hepatic artery goes into the tumor here, but the right is free. Right anterior, right posterior sector. And on the side view, you can see how the left portal vein hugs the tumor here in segment 3. At this stage, this is what we achieved in 7 months of neoadjuvant therapy. Now, a post-text 2, and it was decided for a left hemipectomy, a segmentectomy 1, with regional lymphadenectomy, a surgical time of 90 minutes, and 2 Pringle maneuvers of 10. It was an R0 resection. The closest margin was 4 millimeters, 0 of 8 nodes, and an M0. Patient is discharged postoperative day 6 with the grade A bile leak, which in 9 days post-op was resolved. So 6 weeks after the surgery, patient's at home, comes in the outpatient clinic with the second episode of pancytopenia. At this stage, we cannot associate it to chemotherapy anymore. So a bone marrow biopsy was performed, and the pancytopenic medullary aplasia was diagnosed. Thank God, I hope you all do in your institutions, we have some people in the background who do a great work. And somebody thought, let's run a bone marrow failure panel on this child. With good luck, they found a mutation in FANCC gene. This is something also new for myself. And posterior of this information, I got introduced to this handsome senior. This is none other than less than Professor Fanconi himself. So we have a Fanconi anemia patient with a hepatoblastoma. We had to change the post-text management immediately. So adjuvant chemotherapy was suspended, and a bone marrow transplant was proposed at one stage. In between these managements, the patient did the 4th episode of pancytopenia. This is 7 months after surgery, and associated with a multifocal pneumonia, and sadly passed away at this stage. So this was all a bit shocking for us, because whoever has managed hepatoblastomas knows that the overall survival of these patients are very good, between 80 and 90%, independently if you transplant or you resect. They do very good. Even at higher ages, up to 4, you still have a good survival rate. So what is happening? What happened here? So looking a bit into Fanconi anemia, really there are about 2,630 tumors in solid organ associated to people with, also patients with Fanconi anemia, and the liver is the 3rd one in range. After the brain, Wilms tumor, it's the liver. So about 30 plus liver cases have been described in same situations. But what has happened? Well, if you search the literature, you will find yourself with lots of case reports, interesting cases, case studies, and clinical observations. And most of them, sadly, end with a similar problem that this patient faced. So here comes the question. should we transplant, bone marrow transplant these patients before we do liver surgery or chemotherapy or liver transplant? Well, there's not much information either, and there is this 47 reported cases where bone marrow transplant was made prior to organ transplantation. This includes not only liver, it includes also kidney and etc. And they found out that the mortality rate was at 71% if you do the transplant in the 4 months after the bone marrow transplant. But 4 months with somebody with this kind of pathology is it's not manageable. So what they found out also is after 4 months there was no mortality, but you cannot wait the chemotherapy for 4 months until you do it, but it doesn't work. So where are we today? Should we stratify the risk of these patients differently and can liver transplantation be considered an option in these patients? So a combined liver transplantation. Thank you.
Okay, comments? So I would say, for example, in this case, I don't think hepatoblastoma is something that we have a lot of experience, as most of us treat adult cases. But still, I've never heard of a
It's a bad, let's say it's a bad, that's why the title, it's hepatoblastoma alone is manageable and you have easily good results. Now, you cannot suspect congenital abnormalities in each patient who has hepatoblastoma. It's also, you cannot test everybody for this. It is not, you can't do it in practice. But for these special groups, especially here, even if it's a small number, it's only 47 cases, with this 48, maybe there should be a protocol developed for this, or a small one. So you check this first if you have this.
Does anybody have experience with this? Eduardo.
We have had some experience in treating patients with hepatoblastoma and received previously chemotherapy. In some patients, we have the opportunity to resect them. In some patients that the tumor recur, we have chemo again and transplant the patient, but we have not had the experience of the patient with a bone marrow transplant. So we have not this experience. But the results in hepatoblastoma with transplant or with resection after chemo in this patient is really very good.
I should say also the same thing. We have almost 20, we are reaching perhaps 20 cases of hepatoblastoma, excellent response to chemotherapy, excellent results after resection with a very high survival.
Completely agree. The survival for hepatoblastoma, if you independently, if you transplant or resect, as long as they get chemo prior to, like the pretext, is at 80 and 90%. For transplant at 85%, even at 12 years. So these are great results. It is so. That's why this is so shocking when you can't manage an hepatoblastoma, like we say.
And I can add that in most of the patients that we transplant, these small patients, we use in all the cases living-related donors.
Okay, Lee, and then
a question
Riccardo.
about experience with hepatoblastoma in adults. I just recently took care of a 60-some-odd-year-old patient, otherwise unremarkable, with no significant history that would have alluded to any of this, with hepatoblastoma. And this is confirmed by our GI pathologist and reconfirmed in another hospital, because I guess the fact was that none of us had seen this pathology in this age group. So we leaned on our pediatric colleagues to know best how to take care of this patient. Was something, I mean, I have to admit, none of us had seen. So we did a resection, negative margins, patient did very well. The real question was, what do you do with this as more of a complete treatment, global treatment for this. Do others have experience in this age group that we might be able to benefit this gentleman from? It's a very unusual one-off. I have no other experience.
No experience also.
No.
This patient is 7 months.
Pediatric oncology decided, well, it was proposed. We didn't have time to perform the bone marrow, but the treatment of Fanconi anemia is a bone marrow transplant. The thing is, normally the evolution of this Fanconi anemia does not start at 7 months of age. It normally starts at 5 years until teenage years. Now, the hypothesis here is that due to chemotherapy, well, that this crashed the patient into having an earlier onset of this disease, because, as I said, the first episode we associated to chemothotoxicity, but after you have a patient over 7 months without chemotherapy, where do you associate pancytoplasia? You cannot associate it to chemothotoxicity, and this is so complex.
Riccardo?
The problem, congratulations, Manuel. The problem here is that to treat the Fanconi anemia, you should bone marrow transplant the patient with an hepatoblastoma. So the protocol is impossible. Or you transplant the patient without chemo, and you don't know the results because the only thing we know of resection and transplant is after chemo and excellent responses. Here, probably the trigger was the chemotherapy in the Fanconi anemia. You cannot bone marrow the patient because you have to immunosuppress the patient after bone marrow transplantation, and the hepatoblastoma will explode. So here, the only option is to transplant the patient without chemo and knowing not the results. You have to take the risk. Probably the result will be particularly the same. Even though if you knew the patient had Fanconi anemia before you treat the patient, it is a very hard decision to make. Or you take the chance to do chemo, knowing that he can zero the bone marrow and we will die of sepsis. Or you transplant the patient without chemo, and you don't know what's going to happen in terms of the tumor and in terms of the Fanconi anemia. So probably these patients with the association of hepatoblastoma and Fanconi anemia could have a 95% chance of dying.
Yes, that's basically yes. And there are cases that a bone marrow transplant has been performed before a solid organ transplant, including liver, but you need to wait 4 months between one and the other. And in these 4 months, you cannot treat the patient for the hepatoblastoma, so you don't know what stage you will encounter this once you're done. And it doesn't help to treat the Fanconi anemia if afterwards you have a grade 4 hepatoblastoma. So,
and actually, you have to think that the frequency of this type of complication is very low.
Yes.
So probably we shouldn't change our approach, I think. But Gina.
I just have a quick comment because your case is very interesting and I had the opportunity to see what they do, but you have to just think to be more pragmatic, especially this case. So that's why I asked you how old is the patient. You told me 7 months. So now you have to make a decision regardless of what the science tells you. And I agree with Eduardo. For these patients, especially at that age, you have to think about living related. And it will be a monosegment transplant. Mm-hmm. That's what you have to discuss with the family. And it's monosegmental transplantation. You have to think first about the liver, then you consider the oncological process. Yep. This is the case of saving the life of a baby. So first step, I do that. Then I treat the second step, the oncological. I might give you, I mean, that's the work of Moreo Kazahara in Tokyo. He's only dealing with pediatric, really infant transplantation, and he has a great experience in that case. But that's what would be my first approach for this patient.
Okay,
think pragmatically.
We have to move on. Thank you very much.
Thank you.
And I call Marcelo.
Good morning. I'd like to say that it's a pleasure for me to make part of this selective group of visionary surgeon under the leadership of Professor Bismuth. We have participating for many meetings for a long time in Brazil, 2016, in Portugal, the presidential house. And I know that it's very difficult to organize a meeting like that, and I congratulate Guido for the nice meeting that I had the opportunity to see the sparing the parenchyma liver surgery here with him. It's very, I congratulate because it was a big surgery, a good surgery. So I will present the case. Is a male, 15 years old, single. Main complaint of change of bowel habits with losing of stool and blood. He had a loss of 20 kilos in 4 months, no relevant past history. He had an excellent performance status, and the physical exam was normal, except for the friable and ulcerated stenosis lesion at 3 centimeters from anal verge. The laboratory workup was normal, accepted by the CEA, that was 35, and the colonoscopy of external service showed extensive and friable circumferential substenosing in rectal lesion at 8 centimeters starting at 3 centimeters above the anal verge. And the pathology report of another center was adenocarcinoma. The CT scan, the previous center was this. Multiple lesions in almost all these liver segments. MRI. Multiple confluent lesions in the right liver, but in the left liver also. And this is the total presentation that the disease. And the rectal, there was a massive lesion in the lower rectum with invasion of a seminal gland, no definitive plane of section between the tumor and the gland, and multiple lymph nodes in the fat beside the rectum. This is the report of the CT and MRI. And I ask you if it's, at first, if it's resectable, which approach would you do to this patient? And if it's not resectable, which is the approach in terms of chemotherapy or palliative care, or any other strategy? Symptomatic, yes, bleeding and pain. It's good. T3 is, yes.
Okay, Mark and Laurence.
I would maybe go pragmatically 5x5 radiotherapy of the rectum and then chemotherapy and wait response and see what's happening.
Laurence?
It's a very advanced disease, rectum and liver mainly. So we would do a very strong chemotherapy, what we call induction
Which?
chemotherapy for FOLFIRINOX plus targeted therapy, because we want a fast and important response if it's one day curable. But that's what we do, a strong, very heavy chemotherapy, which will be efficient on the rectum, on the symptom of the rectum, and on the liver. So 6 cycle, 4 cycle, and then evaluation.
Bashar?
Neoadjuvant radiochemotherapy and heavy chemotherapy as well, and then reassess.
I would in fact, John, I would in fact postpone radiotherapy at this point, because for now you need systemic chemotherapy and wait for a response to think about local treatment of the rectum. I would have the same opinion as Laurence. John?
I think we all agree that he needs induction chemotherapy and restage. And treatment, symptomatic treatment, radiotherapy, yes, but is he obstructed at this point in time? Is the patient bowel obstruction?
This is not obstructed at all, but it's close to obstruction.
You know, you may need ileostomy or colostomy while it's...
Became non-systematic after 1 or 2 cycles.
Okay. So the tumor board decided to, it's a rectal tumor with synchronous bilateral liver metastasis, like you told. No extrahepatic metastasis, good performance status. So we decided to perform the loop colostomy and liver first approach after observing the response to chemotherapy. We decided for FOXFIR, 7 cycles with good tolerance. And the patient had a white type RAS mutation, no mutation, MSI negative and BRAF negative. And due to the toxicity, we changed to irinotecan and cetuximab 2 cycles. It was during the pandemic. It was very hard for us to obtain the chemotherapy in Brazil. It was a difficult time. And the CA decreased from 117 to 23. The CT scan after the chemotherapy, the patient had a good response, recovered the weights, and it was very good in terms of clinical response.
So Marcelo, just one question. You just did 9 cycles of chemotherapy.
9.
Why wouldn't you go to propose surgery before that? Because it looks like an excellent response, and probably after 4 to 6 cycles, you would already have a good response.
Yes, in fact, at first we didn't think it would be good to make the surgery before, and we, like I told you, you had many difficulties to operate this patient before, so it was hard, and I think we wait for the excellent response to the chemotherapy.
Okay.
So the MRI, we have radiological good response. This is the final exam. And the rectal, we could see a restricted lesion close to the gland, but without lymph node visible on the fat, perirectal fat. So we decide for the liver resection.
For the optimal timing for rectal surgery, we would perform the liver surgery. And you can treat the patient in one stopping chemo time.
Yes, it could be. It's
Normally, in these patients, we do the radiotherapy, and we schedule the liver surgery in the 12 weeks that we are waiting for the time of radiation.
Okay, but we performed before the surgery, the liver surgery. The liver was good. We performed the ultrasound. It was interesting because the left side, we could not see the most part of the tumor. The palpation, we could not feel the tumor. It was interesting because we have seen just the 2 lesions on the left, and we performed the right hepatectomy. The liver was good, like that. And we removed all the lesions or the scars that you could see. And the ultrasound could not see any other lesion on the liver. It was an excellent response. It was good for us, for the patient. And the pathological specimen, there was a complete pathological response in all the lesions of the right side, the right liver. Like we have a dystrophic calcification. The liver, normal livers here. We can see any cells, tumor cells in this region of the tumor. The other 2 tumors, segment 3 and segment 4, the same, complete pathological response. We had sclerosis of the tumor, the liver normal, the calcification. We could see also the xanthogrammatose macrophage in the entire region of previous tumor. You can see the macrophages with xanthogrammatose fibrosis, but any sign of cells. So we had an excellent response, total response. We decided to perform a short course of radiotherapy in the colorectal resection. The colorectal group performed the mild surgery because it was too lower and then compromised the sphincter and the anal verge, and it was completely dysfunctional. And there was also a complete pathological response in the colon. We have 2 exams after this surgery in September 2022 and 2023, March 2023, with no evidence of disease. PET-CT also, we could not see any viable tumor. So it's a little bit discussed, this subject. It is not just the patient with total response. We have this new paper, Chinese paper, 2020, with almost 500 patients and 30 pathological complete response. It had 6% of pathological complete response, and there will be 70% of any experience of recurrence or cure of the patient. And when they did the univariated analysis, it found that the irinotecan-based chemotherapy is association with the complete pathological response. In the multivariated variable analysis, they found T category, T1, T2, right colorectal primary tumor, tumor size in the liver less than 3 centimeters, and preoperative CA less than 20. They are the results associated in the multivariable analysis. You can see clearly the benefit of this response, 85% of the patient in terms of overall survival rate in comparison to the patient that didn't have complete response. And disease-free survival rate also 73%. It's like a cure of this patient. So with the discussion that you had previously in this room, we asked about until when will this kind of disease will be treated by the oncologist without the help of the surgeon. For sure, like Professor Adam said yesterday, we always have to operate the patient to prove that there is a complete response, and that radiological exam is not enough to say or to guarantee that we have a pathological response. So I want to hear you.
Thank you. So time for one quick question, and then we close the session. Mark?
Very short question. Why did you operate the rectum? You had a complete response of the liver. You know that very often the rectum is complete response. In the Netherlands, we have 20%, 15-20% complete response. We don't operate. We just follow up with MRI, biopsies, echo.
Yes, it's a good discussion. It's a good discussion. They had, it was not decided by our group, it was decided by chiropractor. It was completely dysfunctional, the rectum. And I think they didn't have they were not sure about the complete response. Perhaps it was because of that. They tried to reconstruct the transit, but there's infiltration and fibrosis of the anus. It was impossible to reconstruct.
Okay.
Okay, thank you.
Thank you.
All right, thank you for all the speakers. I have to close the section, and we go to the interval. Thank you very much.
Intéressant. Intéressant.